Ladies and gentlemen, tuberculosis of middle ear, I want to share my experience. And you see a lot of tuberculosis cases coming in nowadays than before. It has become a major health issue in the developing countries like India because it amounts to almost to the tune of 4% of head and neck tuberculosis presents as middle ear tuberculosis. And the presentation is varied, indolent and heterogeneous, and we need to suspect whenever there is no response of CSOM with routine treatment, we need to suspect. Lack of suspicion leads to delay in diagnosis. So it presents with painless discharge with multiple perforations, often with pale granulations and sensory neural hearing loss disproportionate to the disease and the facial nerve paralysis and sequestra. And patient not responding to the treatment is the most common presentation that we need to understand. That it can be secondary to pulmonary tuberculosis, laryngeal, pharynx or nose. Roots of spread would be eustachian tube or external renal hematogenous. And my study is a retrospective observational study of 25 years in the private practice with a material of 22 patients, males and females, this number, and all the patients were about 16 years. The assessment is done most of the times with mutant audiometry and AFB staining, histopathological examination, TB PCR and CT scan. Out of 22 patients that I have treated, 18 were operated and 4 were treated only with ATT, and all the patients received ATT. So this is the varied type of presentation which the patient may come with. So this is the common presentation would be theoretically multiple perforations, but it's very rare. See, this patient has referred to me to thinking that it's a cholesteatoma. You can see the leathery type of tissue in the middle ear through a perforation. Then once I opened the middle ear, then I can see a lot of granulations, and I did a open cavity mastectomy, removed all the sequestra, granulations and everything, and the facial nerve was dehiscent, and the tissue that we sent for the histopathological examination came out to be actually the tuberculosis, and the patients improved post-operatively after the disease removal, facial nerve function is improved. And this patient presented with CSOM, central perforation, not responding to treatment. So I removed all the granulations. Again, the granulations suggestive of tubercular otitis media. After ATT, patient did well. Same kind here, patient presenting varied symptomatology without a proper diagnosis. All mushy granulations from the mastoid middle ear removed, and incus was also removed to remove the disease, and osculoplasty was done. And the patient was confirmed post-operatively to have tuberculosis, and then ATT was given. Again, the patient became TA became normal, and this patient also presented with varied symptomatology, like sometimes he will present with ear discharge, sometimes with pain, sometimes deafness, and it was very confusing. So then we did a CT scan, and a lot of coalescence was there. So I opened the ear, the mastoid, lot of granulations are there, but no tuberculosis, no cholesteatoma. So I sent these granulations for actually histopathology. It came out to be tubercular otitis media, and the patient is doing well after ATT, and then the patient is under follow-up. And again, this is a 25 years old male with facial nerve paralysis and sensory neural deafness, and then there was like this, the tympanic membrane presentation was like this. I just did a small tympanotomy and took the granulation, sent it for histopathology. It actually doesn't have any, it is not concluded, and then TB PCR also not concluded. But keeping the clinical features in mind, I started with ATT. Patient improved well, and this is the picture after 3 months of ATT. You can see the tympanic membrane almost becoming normal, with almost the hearing is improved, near normal. And this patient had tuberculosis otitis media. Then the other side, we had to do a tympanoplasty and then ATT. So then most of the times the diagnosis is made after surgery than before surgery, because the granulations, first whatever we get will not yield much of AFB in the tissue that we send. There is a poor yield of, as we all know, that the extrapulmonary tuberculosis because of probably a secondary infection. So the most of the times it is the surgery from where you get a sample and then get your diagnosis confirmed. And in my study, only one patient had pulmonary tuberculosis, and all the patients are doing well. The ear became dry, hearing improved, and the facial nerve function improved. Follow-up of 5 years, there was no recurrence of disease. So now I conclude by saying that if at all your patient presenting with CSOM not responding to medical line of management, please think or keep in your back of mind that you may be dealing with a patient having tuberculosis. Number two, presenting with atypical symptoms like sometimes thickening of the tympanic membrane, sometimes ear discharge, sometimes bloody discharge, sometimes protective deafness, again sensory neural deafness. And the picture keeps changing from time and again. So now you will be confused as to what you are dealing with. So then you keep tuberculosis. Then whenever the diagnosis is difficult, so please get a radiological investigations done. But mind you, there are no definite features that would tell you that you are dealing with a case of tuberculosis, because it shows granulations, haziness and all. So it will leave you with the confusion. Then when you send a swab for Jaden staining, it yields poor results. It doesn't mean that it is not tuberculosis, because you have to keep in mind that extrapulmonary tuberculosis AFS yield is very less unless you send the tissue, and then so sequestrum has to be removed. So whenever you have a doubt like we had over a period of time gained experience, then we gave only ATT in some patients. They did very well after 6 months of ATT with full improvement. So without surgery, you can also give ATT and then get good results. So ATT for minimum 6 months, search for primary focus, and follow-up is mandatory. Sometimes you may have to extend your ATT maybe for a period of 8 months, but in my experience, with 6 months of treatment, most of the patients did well and there was no recurrence. Thank you for your kind attention.